another question I'm going to also pull from the Q&A session because I think the Q&A questions are excellent. So we've talked about, importance to get a post-progression biopsy, and sometimes it kind of this makes us adjust our treatment. What if your patient is progressing in a CNS only? You really cannot easily get the tissue unless you're resecting, and we can talk about, is there a situation where we go ahead and resect the brain met? How do you test for the new mutations in this situation?
I can try to answer that. I'm typically not testing. I think that's a really difficult area to biopsy, to be honest with you, because every decision point, like Dr. Iyengar said, is critical. And so we need to think about what's the pros and cons of going after an area where it's really tough to biopsy. That being said, I do think it's really important to get another liquid biopsy, right? If there's not an opportunity to have a feasible tissue biopsy. Tissue biopsies are gold standard because we can not only see and appreciate some of the acquired mechanisms of resistance that I talked about on target, off target, but that's the only way, right? If we get a tissue biopsy to see if the cancer cells themselves have changed to something like small cell lung cancer. I can't even tell you the number of cases I've gotten from different hospitals where the patient at time of progression, being on a targeted therapy, went and got a liquid biopsy. Liquid biopsy didn't show anything meaningful, but then we went and got a tissue biopsy and we learned, hey, this actually changed from non-small cell lung cancer to small cell lung cancer. That's a huge change to appreciate. So my answer in a long about fashion is to say it's not always feasible to get a tissue biopsy. Advocate for a liquid biopsy. And if you get a liquid biopsy only, sometimes that doesn't solve it. So a lot of nuances to appreciate.
And we've talked about brain CNS, and there's certain things we do for that CNS progression. When you look on ex-CNS progression, do you look at them differently if it's like liver, adrenal, bone, or it's not the site that makes you do different decisions, but rather the number and the number of the progressing sites?
I think, just the secondary analysis we did on that LU002 trial where we consolidated, the patients that had liver mets did worse. And that's not surprising. I think people have thought about that once disease gets to the liver, it's going to be a little bit difficult or more challenging, but it doesn't mean that it's the end of the road. I think that we just have to come up with, other options. And some people, there's a trial here that we're doing where, we're aggressively radiating the first signs of any liver disease from metastatic non-small cell as a means of trying to change the trajectory of the disease makeup. And so, yeah, I think personally, the presence of disease in the organ is probably more critical than how much disease is in the organ. But these are all things that we could figure out with the data sets that we're looking at, but I still don't have a lot of insight into that. What about you guys?
Well, I think if a patient's on immunotherapy and they develop a disease in the liver, I am more concerned about the effectiveness of immunotherapy and would certainly advocate for that patient getting chemotherapy or changing the chemotherapy. For patients on targeted therapies, if we're thinking about additional targets, I think targeted therapy is actually pretty effective in the liver. So it's different for each patient scenario, but I agree that the site is not as important in terms of choosing the next therapy.